Hello, everyone, and welcome to today's webinar. My name is Leah Ishraghi, and I am the Senior Director of Clinical Research at Dr. Susan Love Foundation for Breast Cancer Research. We are very pleased to have you here for this exciting collaborative webinar with the Wisdom Study, which is one of the incredible ongoing studies that is supported by Dr. Susan Love Foundation. We chose to do this webinar as a collaboration because we felt that the topic of diversity in research is very multifaceted, and it's important that we understand all of the different factors that give context to the overall necessity for inclusion in breast cancer research. By including the perspectives of medical doctors, researchers, nonprofits, and community advocates, it is our hope to facilitate an open conversation that unites these perspectives and sheds light on the ways that everyone, including all of our viewers, can help combat the disparities that exist in breast cancer research. So just a few housekeeping items to start us off. Today's webinar will be recorded and available for online viewing. Registered participants will receive a link to the webinar within 2 business days, but you can also visit the link that will be included in the chat box, which includes a full listing of all of Dr. Susan Love Foundation's webinars. Please note that we will be dropping helpful links into the chat box for your convenience throughout the webinar. We will be accepting questions from the audience via the Q&A feature in Zoom, which will be answered at the end of the webinar. Please feel free to submit any questions you may have for our guests and panelists, indicating if there is a specific person you wish to direct your question to. With that, I'd like to briefly introduce the Foundation and the Wisdom Study. The mission of Dr. Susan Love Foundation for Breast Cancer Research is to end breast cancer. As we work towards this goal, we drive collaborative, cutting-edge research with non-traditional partners, shed light on the collateral damage of treatment, and actively seek ways to diminish it, and interpret science to empower breast cancer patients. Through our signature program, the Love Research Army, formerly known as the Army of Women, we are committed to encouraging and facilitating breast cancer research in all people, regardless of age, race, gender, sexual identity, with or without a breast cancer diagnosis. Through the Love Research Army, we thoughtfully engage over 380,000 members by providing them with ongoing real-time access to an array of studies. And one of these studies is the Wisdom Study, which aims to determine the safest and best way to screen and detect breast cancer for all women while reducing the number of false alarms and biopsies. Wisdom is doing this by comparing annual mammograms versus a new personalized approach to screening based on each woman's individual risk factors. Their goal is to learn which is better for all women. By recruiting a robust and diverse participant pool, they are one step closer to achieving this. To share more about the Wisdom Study and Dr. Susan Love Foundation, what they're doing to combat disparities in breast cancer research, I am pleased to welcome our first 2 guests, Dr. Laura Esserman, Director of the UCSF Breast Care Center and founder of the Wisdom Study, Dr. Susan Love, Founder and Chief Visionary Officer at Dr. Susan Love Foundation. Dr. Esserman and Dr. Love, thank you for being here today, and I'll let you take the floor.
Okay, thanks. And so you're going to advance the slides, right?
Yes.
Yeah, perfect. So the first question we have to ask is, why do we screen? Why are we screening for breast cancer, and why are we talking about breast cancer in the time of COVID? And the reason is because breast cancer is still the most common cancer in women and the second most common cause of death from cancer. And in the US alone, over 40,000 women die of breast cancer. So it is a serious and important disease, and we have to have some urgency about solving this problem. And these numbers are despite screening every year. When we started screening in the 80s, we thought this would go away, but it hasn't. So clearly we need to improve. So one of the things we want to do is apply what we've learned about breast cancer treatment to screening. And breast cancer treatment today depends on tumor type. We don't treat everyone the same. Next slide. And so, first of all, how often should we screen? The reason why people are confused about this question is because the experts are clearly confused about this question. These are just 7 of the guidelines that are in the United States. And by the way, none of them agree with the guidelines that are actually out in Europe in most of their countries. So this is a lot of smart people looking at the same data, coming up with very different recommendations. So clearly there's emotion and concern. It's just confusing. And I say is, why are we, and you know what, this is all based on data that's 30 years old before we even knew what an estrogen receptor was. So it is really time for us to move forward, stop arguing about the past and create the future. But if we want the future to apply to everyone, that means everyone has to participate. Next slide. So who gets breast cancer? Well, that probably depends on your risk. Family history, genetics, breast density, age, your race, ethnicity, other breast disease, lifestyle, and exposures. Do we take that into account? Does anyone ask you about that and use it to determine when you screen? No. The next slide. So the problem is that we have made a lot of advances. We know a lot more about breast cancer prevention. We actually can figure out we have at least a good first pass about who should be thinking about prevention. If you have a high cholesterol, if you have a history of heart disease, if you have a history of stroke, someone's gonna prescribe a statin. Well, we actually have data like that, but who's having these conversations? How are we integrating screening and prevention? What about risk assessment? Well, we now know there are like 9 genes that are associated with it, even though it's not a lot doesn't account for a lot of the cases in the population. We know who's at risk for the highest, who had the highest risk. Do we use it in daily practice? No. And what about some of the minor changes in your genetics? Are we using that? No. Could we? Yes. And there are legal challenges that have made it possible, right? So there's the GINA Act, which allows you to have a privacy that you can't be discriminated against because of genetic information. The Affordable Care Act actually means that you can't be discriminated against on pre-existing conditions. So all these conditions make it possible to be able to do things. And because the Supreme Court said no one can own the genome, all of a sudden it opened the door to technology to dramatically reduce the cost of doing these tests. So instead of asking 2 hours of questions, we can actually run a test for the same price as a mammogram. So the world's a different place than it was 5 or 10 years ago. Next slide. And that means you out there should be demanding something different. Next slide. So why is disparity important? Because, as rates of breast cancer screening have increased in the African American community, so their rates of breast cancer are increasing, but the mortality rates are still a gap. So why is that? Because there's probably information about who's getting what kind of cancer and trying to figure out how to tailor prevention in different ways. Who's at risk for these more aggressive cancers. And it doesn't matter if you're Latina or Black or white, anyone can get these aggressive cancers. How are we thinking about this in a different way? And so these disparities are persistent and problematic, and we have to be committed to solving the disparity. And so that means when we put a big trial together to try and find better solutions, we have to get everyone to participate. Next slide. So that's keep going forward, keep going. Okay, so how do we do this? Well, first, we need a large-scale trial to provide new data. And we actually have this chance to test this new approach that could make it more personalized and save lives, so that people who have this higher risk actually realize it, are coached, and know what their options are. This allows us to educate people about health education and prevention options when they know that they have more risk. And we want people to know, regardless of who they are, a lot of the studies, a lot of the ways in which we look at genetics, really our data come from women of European ancestry, and that's because that's who was in the trials. So we can't have that in our new trials. We just can't do that, make that mistake again. Next slide. So the wisdom trial is really designed to say, okay, what's the gold standard? And a lot of people think that screening every year starting at 40 is the gold standard. We are saying there must be a better way forward. But the first thing we have to do is say, we have to prove that it's just as safe. So the first and most important thing is it just as safe? Does it reduce these false alarms? Will women accept it? Does it increase the breast cancer prevention uptake? And can we make it better for outcomes, better outcomes with the same resources, and continue to do more for those at risk and less for those who's not? Next slide. So this impacts the larger population. So we're trying to get 100,000 women of screening age And we are trying to do this nationwide. Anyone 40 to 74 who's never had breast cancer is eligible, and participation is easy, but it requires a commitment to be part of this really important landmark study. Only you out there can make a difference, and the only way we can make sure that it includes women of diverse backgrounds is to make sure women of diverse backgrounds engage and enroll in this study and help us gather the data to find out whether we can, and that includes that personalized risk assessment, including genetic testing and high-risk counseling and risk reduction tools. That's the only way we can sort this out. Next slide. So I already talked about this, but anyway, so next slide. So we're really trying to do this nationwide, and we want everyone out there to help us transform women's health. And I think this is like the Women's Health Initiative or these big landmark studies. This is a study for women, by women, and about women. You know, if we need to enroll more women with diverse backgrounds so we can improve health outcomes for everyone. And it's a study that's large enough that we can do that. So very easy, anyone can do it. And it's a great thing to do while you're sheltering in place. So you just have to go to the wisdomstudy.org and sign up. If you're already a participant, we're so grateful. So thank you. Tell everybody in your professional networks, in your professional community groups, your social circles, social media, tweet about us, tell your friends, your family. This is something we can only do better if we can only know better. We can only do better if we know better, and we can only know better if everyone is part of it. So thanks. I think that's it. Yeah.
Thank you, Dr. Esserman. Dr. Love?
You're on mute, Susan.
Dr. Love, you're muted.
Hey, thank you. I just wanted to talk for a few minutes about the Dr. Susan Love Foundation for Breast Cancer Research and what studies we're focused on at the moment. In addition to, so we both have the Army of Women where we help recruit for other people's studies, and we do some studies ourselves, only on women because and men, but not on animals because rats don't actually get breast cancer. So one of the studies we're looking at that I'm very excited about is the Mapping the Breast studies. And believe it or not, the breast is the only organ that we don't know the anatomy of. We don't know how many holes there are in the nipple. We don't know where the ducts are. Nobody ever bothered to study that. And in fact, Ashley Cooper back in the 1800s drew this whole picture. And then if you read the footnote, it said that he laid the ducts out artfully so they'd be pretty rather than the way they were actually in the woman. So we really need to understand where the ducts are in order to be able to figure out how to get to breast cancer much earlier, because it starts in the lining of those milk ducts. So I've been trying to do this for years, and I've tried it in a number of different ways, but I finally got it. We finally have a way to do it. And it involves a type of ultrasound, which is the transmission of sound that goes across the breast. You lay on your stomach with your breast hanging in water, and this ultrasound goes across and then collects the data on the other side, and you can analyze the data and come up with a map of that woman's breast ducts. And you can see cancer in the duct, you can see invasive cancer, you can see DCIS in the duct. And so that's going to allow us to then know which hole in the nipple to go in to get to that duct. We could get a few cells out that way, almost like a pap smear, and we could maybe even squirt the treatment down the duct and clean it out if it hasn't got along so far. So we'll be starting this study as soon as the pandemic rises a little bit. We're going to have a machine in LA, and we'll be recruiting healthy women of all ages and all types, and maybe even a few men, so that we can really come up with, these are the main anatomical distributions of the ducts, these are the variants, and really have an answer to where breast cancer starts and how we can get to it. While we're at it, when they did the Human Microbiome Project, they didn't do the breast. So we're also looking, they forgot about it. They did all the organs of the body but the breast, which gets sucked on by Tom, Dick, and Harry. So you know it has bacteria and viruses. So we're going to be looking at that at the same time. We've done a little bit of studies showing that the duct with the fluid in the duct with cancer may have different bacteria or viruses than the other ducts. And then our third project, which we're doing in Mexico, thank you, is the self-reading portable ultrasound study. So the idea is most lumps in premenopausal women, most cancers in premenopausal women are going to show up as lumps, especially when they don't have screening. And most lumps, though, in premenopausal women are benign. So if you could easily figure out which ones you have to pay attention to and which ones you don't, that would help a lot. And ultrasound is good for that. So this is a type of ultrasound using artificial intelligence. We're using it on palpable lumps you can feel. You'll take 2 pictures of it, and then it'll give you a red light or a green light. So that the ones that are clearly benign, you can stay home and they don't have to go in and get biopsied. And the ones that could be cancer will go in, and that'll cut a lot of the waiting time and a lot of the travel. So that study also is on hold because of COVID, but is well underway and is funded by the NIH. Now you can change the slide. So the Love Research Army has recently had an overhaul. It started out, as many of you may know, as the Army of Women, but now we want it to include everybody, because research should include everybody. So it's we want men, we want women, transgender people, we want anyone who wants to help us accelerate research on breast cancer. And what we do is it's a big email list. We send out, people come to us with their studies, we vet them, we send them out to everybody, and then the people who fit the studies get to RSVP, and then the researcher will contact them. So it's very easy. It's just it also keeps you abreast at what research is going on. You don't just hear from us when it's something specifically for you. You hear about all the studies, and we hope that when you fit one and you see a study and you don't fit, you pass it on to somebody else. So we encourage you, if you haven't joined the Love Research Army, please do. Anybody can join. It's all we want from you. We don't take a whole lot of information, just your email, because we know your medical information is going to change over time, and we don't want to have to keep it up to date. So it's a big email list. It sounds fancy, but it is an army to try to get research done on people. So please join us with that.
Thank you, Dr. Esserman and Dr. Love, for being here to give us that important overview of the state of diversity and inclusion in breast cancer research. So now that we understand from a medical perspective some of the barriers to breast cancer research and care, I am very excited to introduce our amazing panel that will share their unique experiences and insight on this topic. So today, and they're all getting on camera, today we will be hearing from Dolores Moorhead, lead client navigator and multicultural client support clinician at the Women's Cancer Resource Center in Berkeley, California. Deborah Stafford, the founder and CEO of Roar Care and member of Dr. Susan Love Foundation Scientific Advisory Committee, as well as a Wisdom Study Ambassador. Danette Walker, patient advocate extraordinaire. And Lisa Teeler, Executive Director of the Bay Area Community Health Advisory Council. So just a reminder to the audience that our panelists will be available to answer questions at the end of the webinar. So please submit your questions using the Q&A box. While we will try and answer as many questions as possible, please note that we may not be able to address every question today, but you can definitely follow up with us. So I'd like to kick things off by asking an open question to all of our panelists, and that will give everybody an opportunity to say hi. So I'm going to start with a question. When discussing the importance of diversity in research, what do we mean by diversity? Does this pertain to diversity in ethnicity, race, age, socioeconomic status, gender? And Dolores, if you'd like to kick things off, that'd be great.
Sure, thank you. So diversity means allowing individuals and/or participants in research to acknowledge all the identities that they declare states who they are. Diversity also means including all cultural characteristics, such as what you said, sexual orientation, age, disabilities, religion, and I also feel it means also having more than 2 boxes for gender.
Definitely. Thank you, Dolores. Would one of the other panelists like to chime in?
Hi, this is Lisa Teeler. Thank you for being able to participate in this panel. Similar to what Dolores said, that diversity includes, is 3 to 4 dimensional. It's not just race, gender, age. It's also all the various aspects of diversity that are unseen. So geographic location, family history, military status, educational background, religion, your genetic profile, all these things are things that people bring to the table, and that's critical when you're looking at diversity.
Great, thank you. Jeanette or Deborah, would you like to add anything?
Hi, I'm Deborah. And one thing I would like to say that I agree with Dolores on is having more than 2 boxes for gender. And beyond that, I don't think that any person in an intake form or a survey should ever have to mark themselves as other. So there are plenty of ways to do that. Prefer to self-describe. There are many options for that, and I think that is an important way to make studies and surveys more inclusive. And I want to talk a little bit about why it matters as well, which is that we learn things. If we include males in breast cancer research, we can see in cases even not estrogen positive breast cancer, like triple negative breast cancer, that some therapies work differently in men and women, which gives scientists clues that they might want to look further into the role of estrogen in response to therapies. So each of these factors that each of the panelists have discussed so far are critical to our being able to provide the best care for everybody who brings all of these factors to the table.
Thank you. That's fantastic. I think we will go on to the next question now. And this is specifically for Dolores. So this is a multi-part question, and we'll go through a few questions at a time. So Dolores, you work one-on-one with women of color who have breast cancer in a community clinic setting. There are a few parts to my question. From your perspective, how might researchers reach your patients to inform them about studies they can participate in? That's the first question.
Okay, so I believe researchers working with the Women's Cancer Research Center, WCRC, allows them to make us aware of the studies that might be pertinent to the communities that we're serving. And this includes talking to us before the study begins. You know, if they have a concept, then think about what partners, what CBOs can actually come to the table prior to developing the study, and then thinking about how to get it into the community.
Great. And then a follow-up question to that, do your patients express concern or hesitation about participating in medical research? And if so, how can researchers and scientists do better to educate your community members about studies that are available to them?
Well, I can say yes, without hesitation. You know, we have to look back at the historical aspects, you know, the Tuskegee study, the experiment, also the discussions that have been out there about what happened with Henrietta Lacks. So people don't want to be guinea pigs. And when those things come to the forefront of their mind, that's how they see and what they see research being, looking for a guinea pig, wanting to experiment on African Americans, not really caring about who they are. And one way that researchers and scientists can do better is working with us to educate our community and to educate the members. That means what we've been able to do at WCRC is to bring in researchers and bring in team members to sit down and have discussions with our community members about why the study is important, why the researcher is reaching out, and also being available for the individuals to voice their feelings, their concerns, their fears. And one of the individuals groups that we worked with in research actually partnered with WCRC and made our location a site. So our constituents, our clients felt more comfortable and safe coming to our location to participate. And that allowed for them to have a little change in what they may have believed before of who participates in research studies and who doesn't. And they knew that they could trust us. Therefore, they trusted participating in that study.
I think that's a nice segue into the final question that we have in this set is talking about these community-based organizations getting involved and the trust factor. Do you think there's kind of a quote-unquote centralized way to inform various community groups about studies that are opportunities that might benefit them?
Well, I think that's an interesting statement, kind of centralized. I think that just as there's diverse people, there's also diverse ways in which to get in contact with people. I do believe that, you know, scientists should do what Wisdom Study did. They created a community leadership board. They brought people together to talk about what was needed to reach those individuals. I also feel like partnering with CBOs and gatekeepers to educate them, and that doesn't mean on a specific study, just to educate them about what research does and why it's important and why we need diverse populations. I mean, science has already shown that people of color may have genetic mutations that are different, and therefore medication that worked for a white male has different side effects and doesn't particularly work. So it's really about educating the community, and you go to those folks who are in the community doing the groundwork.
Well, I think that talking about that trust and that communication and kind of setting the stage of understanding the research before even talking about a specific project is very helpful. And I think that leads into the question that I have next for Danette in terms of talking about relationships and communication. So as a patient advocate, much of your work, Danette, also stems from having personal, authentic one-on-one interactions with people of color about their experiences with breast cancer. So in taking this approach, what have you learned about the importance of relationship building in communities of color when it comes to encouraging participation in research?
Well, thank you, Leah. Honestly, in my experience and my conversations, there's one word that keeps coming up, and we've touched upon it, and that word is trust. An earnest and honest effort needs to be made to rebuild the trust of especially African American communities, but all of the diverse communities that you're trying to reach. And it has to be authentic because we can feel it, we can see it, and we can feel it. And we want a genuine interest in us. We want to address our concerns. We want our needs to be met when we have these questions. And that's why I think what Dolores had touched upon too is just sitting down and partnering and having these conversations. And, you know, recently I spoke with a Black woman about participating in research and not just about her opinions and her views, but also what message does she have for researchers. And she specifically said to acknowledge the past. And again, repeating what Dolores said, but I would like to read to you really quickly her words.
Thank you.
And I quote, "They need to address the issue head on. They need to say, this is not the Tuskegee experiment, and you will not be exploited, and you will be fairly compensated. They need to tackle the issue with no coded language. Acknowledge, ask for forgiveness, and then demonstrate how this will be different. Convey that your mother will not be treated like Henrietta Lack, and that your father will not be treated like the Tuskegee Airmen. And we need to hear from the researchers, this is your voice, your samples, your decision." People appreciate that. People appreciate the acknowledgement that a wrong was done and hearing an organization say, well, we can't fix that, we can change, and here is how we have changed. So those were her words. And then I feel like now is the time to demonstrate that change. And you demonstrate that change by showing your true commitment, by hiring women of color to be in the positions in the upper echelons of these organizations and these companies and these facilities. And also to have a genuine interest to support not only women of color in leadership positions, because the change comes from the top, but to also support researchers, doctors, nurses, people of color who are doing their own research. When the community sees that your commitment to hiring these diverse people and to supporting these people, they're going to see and they're going to know that you're making an honest effort. And they're going to feel like a part of the community. And they're going to feel like we can start rebuilding this trust. So it's not that, it's not that you cannot have a community that doesn't understand. But I think when you allow diversity to come in from diverse people, your research is only going to be enhanced because we have ideas and experiences that are outside the realm of the traditional researchers, because you guys, you know, are essentially homogeneous. You know, we have a lot that we can bring to the table. And so when given an opportunity to make true change when it comes to inclusion and diversity, I encourage the organizations and the researchers to take it. Just take it, because you're the ones that can make a difference. And in truly promoting and allowing us to make these connections, it's not the responsibility of the community partners, it's the organization's responsibility to show their sincerity. So at the end of the day, when it comes to making a difference in inclusion and diversity, your actions speak louder than words. So you don't say empty words like, we can do better. Just do better. It's that simple. You want to build the relationship, build the relationship. Thank
Well,
you.
I think that was very powerful, and it just goes to, you know, doing the work and not just talking about it, which I think is what we're trying to, you know, talk about here today to figure out what we can do. So thank you for that input and for sharing the feedback we received. So we're going to switch a little bit to talking about some project review that happens at the Dr. Susan Love Foundation. So this question is for Deborah. So as part of Dr. Susan Love Foundation's Scientific Advisory Committee, you support the Love Research Army by reviewing study proposals to determine if projects are ethical, safe in their design, and feasible for the Love Research Army membership. So why do you feel this role is such an important function of the foundation?
I think that we have the unique opportunity to give the researchers some feedback, perhaps even before they roll out their intake forms, their surveys, and that is where we have the biggest impact. So as a scientific advisory committee member, I was tasked to review a study that I felt was not using inclusive language. And after reviewing the study thoroughly, I provided a comprehensive list of edits that would make their study more inclusive and appealing to the demographic they wish to study. In the end, they implemented 95% of the changes I suggested, which showed me that the lack of inclusive language was not due to opposition to being more inclusive, but rather a lack of education. And so we have that role to educate. And one thing that I discovered from that is that I would encourage researchers at academic institutions to not only hire undergrads who are science majors, but reach out, collaborate, consider hiring a student from the Gender Studies Department, the African American Studies Department, to advise on inclusive language and ways to make their intake forms and surveys more inclusive and more appealing. And I think it is so critical that we do this because we have learned that breast cancer is not one disease, it is many. And the best treatments are those that match the specifics of both the patient and their breast cancer. Studies like the Wisdom study are fantastic. It is the prime example of precision medicine in breast cancer screening. And we won't know if we don't ask the question about that particular type of person. So for breast cancer researchers to know how best to treat people like you, your relatives, people who live in your community, people of your age, of your gender, people like you need to participate in research. For example, Veronica Meadows, a breast cancer patient and research advocate, her personal and family history of breast cancer inspired research into a novel, what turned out to be a novel BRCA mutation. And if she had not participated, that BRCA mutation, which is unique to Americans with Black heritage, would not be something that we understood. And every breast cancer survivor I know, especially those with a family history or genetic risk factor, want to be the last person in their family to be diagnosed with cancer. They don't want their beloved children, grandchildren, nieces or nephews to go through the cancer diagnosis and treatment. And the best way to ensure this outcome is to participate in research studies. Give your future generations their best chance to live lives without breast cancer.
Excellent, thank you. So I think we'll stay along that line of conversation about language because that is one of the key pieces of this conversation is the significance of the language used when discussing diversity in research. And so this is a question for all, but we'll get started with you, Danette. So in your experience, what have you found to be some of the ways you've seen language create barriers for people of color?
Well, Leah, honestly, it's the tone of clinical self-importance. I feel like the research is designed to use the participants for the researcher's gain. And that is what comes across in the language that's typically used in these clinical settings. And using words like recruit, it just comes across as cold and self-serving. So I feel like communicating to us in a way that invites us into a partnership, and we've touched upon this, educating us, maybe perhaps including incentives and compensation. Those things are important. And how this will benefit us and our future generations. Like, we need to hear this. We need honesty about why you need us to participate, and we need honesty about your answers when addressing our concerns. So, many people don't want to discuss cancer, and different people have different cultures. So the language needs to recognize the diversity within the diversity and not target people, but just honestly, again, authenticity, reach out and discuss with them, have communication that doesn't serve just the researcher, that it's for us to benefit us and why this is important. And also, honestly, equity in the approach. Leave the degrees and the pompous attitudes behind. Just speak to us, treat us like valued individuals and not like lab rodents or cells in a petri dish. treat us humanely because we are human. We are human. And you're not better than us. A lot of times in researchers and medical professions, they have that attitude, and we feel it and we sense it. You're not better than us. We are all equal.
Thank you for sharing that. Does anybody else have any input they'd like to share on that topic? Lisa?
Yes, I have a few comments to make about that, and both Dolores and Danette have hit some of the key points I was going to be making. In terms of language, trigger words like experiment and being a subject bring up a very painful historical past, particularly among African Americans, as was alluded earlier with the Tuskegee Airmen study, as well as Henrietta Lacks. And then also educating our community. We did a seminar and we brought in folks to talk about the clinical trial process and what that means. And also part of that education was acknowledging what we have been through. And I know that was mentioned. And so acknowledgement of the past is critically important. And then when I also thought about language, I also about translation. We have a community mammogram program that is utilized mostly by our Latina population. And so translation of certain words, being aware of that, being culturally competent about how you approach, and explaining kind of just breast health in general, and then getting into, you know, why it's important to have a mammogram or not have a mammogram or participate in clinical trials, is really, I think, critical. And that showing that this is a benefit for everyone, as was mentioned by Danette as well, is that it's not just a benefit to the researcher, but it's a benefit to the individual and to the community, and that you're contributing, that you're being part of something that's going to help us move the dial in a particular direction. I think particularly communities of color, we are about the community. We're looking to help our community either individually or as a collective. And so that approach is critical. It's not about just getting someone's name on a paper published in, you know, a scientific journal. This is really going to help move the dial. And I think that's really critically important to communicate that.
Well, and I think, Lisa, that talking about that messaging is really important to talk about a little bit more. So historically, the world of breast cancer awareness and research tends to be directed towards white women when it comes to messaging and education. So what are your thoughts? And you've talked about this a little bit, but what are your thoughts about how these efforts can be more inclusive of women of color? And what can organizations and people who lead breast cancer awareness initiatives, efforts, and policies do to be more inclusive to all women in those communities that support them?
So I hate to sound like a broken record, but again, acknowledgement of the past is critical, and not just in terms of experiments that have been done on us, but just the medical system in general is it, as other systems weren't built for people of color. And in fact, we know there's embedded bias and racism in those systems. So I think there needs to be acknowledgement of that. And then also letting people know that, you know, whatever the medical condition may be, that a response to that may be different in different communities. And so that it's important for us to understand that, that we want to get a diverse population in order to see how this drug might be effective. I also think that developing relationships with organizations, as was also mentioned, is really critical. This is not for you to just come in the community, get some information, and then peace out. That you are committed to these organizations. Having community advisory boards is critical. Developing relationships with the trusted messengers and trusted leaders in those communities. The faith-based communities is critical in several communities. And checking in. Images are really important. A lot of times I see brochures about studies and I don't see anybody that looks like me. So I'm like, if you didn't even bother putting an image of someone that looked like me, why should I participate? How am I going to relate to this? How's this going to impact me and my community? And then supporting organizations that are doing the work. Several of us are involved with organizations that are doing this around health. clinical trials, participating in them, reviewing the design of studies, having researchers come to us with an idea before they actually design the study is very helpful, because I've seen protocols where I could have told them from the very beginning this wasn't going to work, but if I wasn't at the table for those conversations. So I think that's really important. And then also what was mentioned earlier is who's running the study, who's in charge, who's the PI. It would be nice to see people that look like us that are actually in charge of the study. Who's the study monitor, who's doing the outreach, I think is also critical as well.
Well, thank you, Lisa. And you actually answered the next question that I was going to pose. You've answered really well. So I'm going to just ask this question to see if anybody else has any input outside of what's already been shared. So, and this is a very important question that you address, Lisa, in terms of how can researchers ensure that people of color trust that if they choose to participate in research, their experience will be safe and honest? So if any of you other panelists would like to add anything to what Lisa said, we'd love to hear from you.
I would like to.
I think
Yes, I would like to answer that. But after you, Dolores.
Okay, I think it's been said, but I really also feel like, explaining to people in language from people that look like them, which we've said, and not using, explaining what does it mean to be part of the controlled arm or the randomized, part of the arm. Also, utilizing and educating the advocates and the folks on the ground and the gatekeepers, making sure that they are informed, and then letting the community know that if they decide to get into a research study and they have questions, no matter where they are along that line, they can ask those questions and they have permission to withdraw without any repercussions, and that they aren't in there. And then what is going to happen to their information?
Deborah?
So I know that I'm going to be reiterating what both Lisa and Danette, and I believe Dolores also in the beginning said, is that acknowledgement of the past is critical, and it's important to understand that trust is earned. We all know this. We have all had relationships, and we have all had relationships where there was a betrayal. And what happens when there's a betrayal? Does it work if you go on like nothing happened and just try to make it work? No. It works if you commit to that relationship, if you lean into the discomfort, if you have those difficult conversations, if you acknowledge what you did and you do the work to find the ways to make it better, to do better. And, the history of medicine in the US, the foundation of what we have, has come from Black Americans, often without their consent. So I think one thing we need to do is we need to honor the participation, even when it wasn't consensual, to our scientific knowledge. The enslaved women who were used in gynecologic research and were the foundation of the man who is designated the father of American gynecology and obstetrics. These kinds of things need to be acknowledged. Also, the Black Americans who contributed to medical knowledge without receiving credit, that needs to be acknowledged. In cardiology, in so many fields, we need to do the work and find out who those Black Americans who are unrecognized are and give them credit. And any scientist any medical researcher working today, it doesn't matter if your people were here during the time of slavery or anything else. If you have learned medicine, if you have learned science, then what you have learned came to you on the bodies of Black Americans. And so we need to first and foremost acknowledge the past and again find ways to do better. And one thing which came from listening to Danette and Lisa, one thing that would be great, why don't we go into some of these disadvantaged communities and provide some science education? Science literacy is terrible in this country. And if we go into South Central LA or some of these neighborhoods and provide that education, I think that could also go a long way in building trust and building a relationship where we're gonna know, because we're in that relationship, what the needs of that community are and how to communicate with them in a way that meets their needs, not ours.
Go ahead, Danette.
Well, thank you, Deborah. I think that was a lot of valid points. And I would like to add not just credit, but also compensation for these things. But I also wanted to just touch back on your original question. And, you know, I have been in the medical setting for many, many years. And the way I've been treated has ranged from very well to also being like unbelievably atrocious. And sometimes it's racist, sometimes it's not racist, it's just thoughtlessness. So I feel like for researchers to communicate with whoever who's doing the trials, who's ever doing the research, to make sure that they take care of the people who are participating. Because for me to to have a conversation and refer someone to a study and then have them be treated poorly, not only is it damaging to them, but it's damaging to me because I put them in that situation. So that's a conversation that needs to be had from the researchers and organizations to make sure that the people who have that underlying deep-seated bias that maybe they might not even be aware of, but it comes out. So just wanted to add that.
Thank you, Danette. Well, thank you, everyone. So at this time, I'd like to take some time to have our fantastic panelists answer questions from our viewers. I think everybody provided just amazing input and personal experiences, which we really appreciate. So I will say to the audience that we'll probably go a little over time today. So if you do have to leave right at the half hour, then it is being recorded and you'll be able to watch it later. So we're just going to keep going. And we will try to answer as many questions as possible, but we might not be able to get to all of them today. So I'm going to get started with a question that we received. What can the average non-activist person do to help ensure diversity with researchers and in study design and trials? And how does this problem change as populations become more multi-ethnic and multiracial? And anyone can jump in on this one. It wasn't directed to a specific person. I think you guys are all not the average non-activist people. You're all the activist people. So I guess the question is, what can people do that aren't in your position, and what are some things that they could do to get involved or to begin their participation as an activist?
Well, I want to say, you know, as an individual who started working in cancer over 30 years ago, I'm that person that they're talking about. And I really believe that it comes with education. You know, it also comes with individuals, programs out there that, like, I know there's a program that happened at UCSF and probably still is, where SPORES, or I think that's what it's called, they were educating individuals who were breast cancer survivors. And I will just say that most of the individuals I knew who participated in that were not women of color. And when these programs are out there to help educate women about science, about medicine, to be able to reach past your comfort zone of who you automatically think of, to invite the woman of color who, yeah, may not be as educated as you think she should be, but she could learn a lot and be that representative. So I think starting out with education, starting out with doctors and those who are treating women with breast cancer to be thinking about, oh, how can I invite this person to be more active?
Great, thank you, Dolores. And so I'm going to go to the flip side because we have a question asking what recommendations do you have to connect educated breast cancer advocates with local researchers? And I think this is a really important question. So how can we do those connections?
Well, the California Breast Cancer Research Project, I'm sorry that I just keep jumping in, but the California Breast Cancer Research Project, I'm a member of that advisory board. They are looking for, since their community, they want someone from the community to partner with the researchers. And I think this is again where individuals, researchers applying for grants need to think about how can they bring in those people. And not everyone's going to think about the California Breast Cancer Research Project, but that is one website to go to because they do education for community-based organizations and new researchers who are from diverse backgrounds to be able to apply for grants. And this is a wonderful opportunity for new advocates who haven't participated, to be involved with research from the ground level.
That's fantastic. I think that's a great suggestion. And I think for everyone listening today, that two very active things they can do to get started is to join the Love Research Army on our website and also sign up for the Wisdom Study as well. And so those are for anybody on here who's eligible for the study or who's just interested in learning more about research, can definitely do one or both of those things. So I see Danette about to unmute her computer. No? Okay.
No, I was going to unmute my computer, but I just wanted to say, to follow up on that change begins with the individual, and never underestimate your power as an individual to institute change. And even within the studies, if you yourself participate in them, and then you can share about them. Or if you're looking for a way to get more active, and you don't have to overthink it. Like, just tune in and see and feel where you're needed and feel where you want to go. It really is that simple. And then take a risk and stand up and make that change. So that's all.
Thank you, Danette. So this is an interesting question that I'm curious to get your feedback on. So the question is, we are so far behind in including diverse people in research. Do you think we need to catch up by doing more studies that just include people of color? Dr. Love, did you have something you wanted to say?
Wait a minute. Yeah, no, I think we probably do. And I think that we should be politicking to the NIH and the NCI and the Department of Defense, the big funders of the breast cancer, of the research studies, as to why they're not including that, and so that somebody who's doing research, the expectation would be that they're going to have a diverse population, and if they don't, they have to give a reason why not. Like, because this only happens in white males who have big ears or something like that, then you could, that would be an excuse. But you can't, but that unless you'd have to write a reason why you're not including everybody rather than why you're going to. Make it like the accepted thing is you're going to have to include a diverse population.
And that is actually, I would say that is definitely what you have to do when you're putting in these big grants. But there are actually studies. There's the Sisters study. There's several studies really looking at specific populations of African American women. There's a specific study on Latino women. So there are several of these, especially really trying to get to catch up really on issues about how ancestry plays a role integrating with risk. And that is actually how we are getting some of our information that, yes, we need to make adjustments based on ancestry, or race and ethnicity, because the majority of women who have participated in the past, or where these data sets have come from, because they've come from a lot of these large studies, or only white women or European women of European ancestry have participated, that's really where a lot of our risk assessment comes from. So while it's important to have these individual studies where you're trying to specifically figure out some risk factors, you also have to have these larger studies where everyone's there, because if you don't know how the data should be adjusted for white women and for African American women and for Asian women or Latino women or Native American women. So if you don't have studies where you also have the opportunity to look at the richness of diversity, you also miss the opportunity to learn how you should be adjusting.
Mm-hmm. And there is an Aztec gene that is in the Latina community that traces back to the Aztecs, actually, that increases breast cancer risk, as well as an African American one. But
and there's actually, it's very interesting. There's actually, the Jewish genes, so-called,
yeah.
the specific mutations that were very common in people of Jewish birth. Well, it turns out it's actually in the Catholic South American community. Why? Because it dates back to the conversos, because when there were all these, in the Inquisition, and all of the people in Spain were thrown out, they came back, they went to South America, became part of Catholic countries. And voila, it turns out they have, origins in the Sephardic Jewish community.
Yeah,
so
you can't, it's all mixed. It's much more mixed.
It's study of migration and population. So at the end of the day, we want to know how we are different, but we also want to know how we are the same.
Right.
I have empathy for anybody who is at risk for a serious and lethal cancer. And I have empathy for the person who has, a shoplifter cancer who's being overtreated. It's like, whoever you are, however you have it, we have to get that information to the right person at the right time and know how best to apply the other information about them. And that's what some of these bigger studies need to be about.
Yeah.
So I'm going to ask one more question, and I think this really kind of ties everything together. So thank you to this person who asked the question. What advice would you give a person of color who is not quite sure about participating in a clinical trial?
Is that for everyone, or do you want that for?
I see Lisa's got a response, I think, and then anybody else who wants to jump in.
I think seeking out just more information about clinical trials. I'm sure all of us could make ourselves available to talk to that individual if they have questions. So I think just seeking out more information and asking a lot of questions. Also, if they maybe find out if someone in their community has actually participated in a clinical trial. Again, this seminar we did a couple of years ago, we had a panel of people of color that participated in clinical trials. And that was sort of the highlight of the seminar, because people could actually talk to somebody that has went through that experience. So that would just be a few words of advice that I would give.
And one thing I suggest, I also say when you're going for a medical appointment, but for the person that's being talked to about clinical trials, they should record it. Because when you're sitting there with a doctor or a researcher or whatever, you can't remember half of it, and you can't write. You start to take notes, and then you can't spell the second word, and you're stuck. But now we all have phones, and we can all record it. So if they're being, asked, record it and say, I want to go home and think about it. And then you can play it to other people. And, when they ask you, is it these different things, you can listen to it and find out. So don't feel like you have to do it right at that second, because that's the feeling you get. And then you're too scared and you can't hear anything, and you don't know what you're getting into.
And I think, you know, I think it's important to know that everybody has that same concern or fear when they hear the word clinical trial. It's not just the African American population, it's everyone says, gosh, I don't want to be a guinea pig. I don't want you practicing on me. And people need to understand that clinical trials is just another way for learning, you know. And I love the Maya Angelou quote that says, the only way to do better is to know better. And the truth is that tomorrow's treatments are in trials today. Now, it is absolutely true that everything we test does not work. If it did, then we shouldn't be doing trials. We should be just doing stuff. But there's a lot of harm to just doing stuff. And if you don't know, you can't answer questions. I mean, a perfect example is in COVID, there are 35,000 people treated with convalescent plasma. No one was randomized. No one was tested. They could have randomized them 30 to 1. And at the end of the day, after all that money and all that resource, we have no idea what the answer is.
Right.
And the truth is, I am frustrated because I want better answers and I want them faster. So the only way you can do that is to run studies and to learn in the course of care. Now, if you're going to be in a study, you first have to ask, well, what question are they asking? Does this apply to me? Am I interested in this?
Is it a useful question?
Will
Sometimes it's not.
this help me? Will this help my sister? Will this help my best friend?
Right.
You know, is there a reason I should care about this?
Yeah.
You know, and maybe it won't help me, but I might as well, and it'll help someone else down the road. Those are the questions you need to ask, because that's what matters. And if someone who's running this trial can't tell you why they're doing it and what question they're trying to ask or answer, then don't do it. But if they can, and you say, wow, that seems important to me, I'd love to know the answer to that. Am I being treated the same as everyone else? That's what you want to know, right? You actually, I always say to people, I treat everybody as if they're my sister. And Susan did too, and does too. It's like, you know, I want as good for everyone. And I want to make sure it's more personalized for everyone. It all matters, right? And we're trying to do better, and we're trying to do better faster, because the people who are seriously ill with cancer or whatever that disease is, they don't have 10 years for us to get our act together to figure out what the right answer is. And the only way we do that is to find, you know, to find the right trials. But, you know, and the reason why as an advocate you should be involved is to help us make trials that are more patient-centered. And that actually helps us. It helps me when I go to the FDA or to whoever I'm working with to say, no, you need to change. You need to let us do something different. This is what people care about. You need to have the voice of the community behind you, because that's how you make change.
Thank you.
I just want to say something very quick to piggyback on what Lisa said, that when I was doing the training for our community health advocates in our Sister to Sister program, I had a woman who had participated in a clinical trial and who could talk about what occurred in her family, what occurred with her daughter. And one of the big things was that she saw and took care of her daughter as she was dying. And when she was able to say, I chose to participate in a clinical trial because I needed to make a difference. And I think we've talked about that. And that it was important for those volunteers to see someone who looked like them, to be able to have those honest conversations, and to also challenge their core belief that we don't participate in clinical trials, because we do. And they were able to see someone and identify with that person. And it made such a difference, along with educating them at the same time.
Great, thank you, Dolores. Well, unfortunately, we are out of time for today. I appreciate everyone's participation, the panelists, Dr. Love, Dr. Esserman, and the audience for joining us. Thank you for staying on longer. This has been, I think we could go on for hours, but I think we'll have to stop here. The webinar has been recorded and will be shared within 2 business days. And if anyone who's attending has questions that were not answered today, or would like to get in touch with either the foundation or the Wisdom Study, please use the contact information provided on screen. And to be part of the WISDOM study, we encourage you to sign up via the Love Research Army by visiting our website and becoming an Army member. By joining the WISDOM study as a Love Research Army member, you can help both organizations further diversify our participant pool so we can better serve inclusive studies in the future. For those people who are interested in participating but aren't quite sure about it, you know, the WISDOM study website has information on there, so you can take a look. You can contact them with questions. And then when you join the Love Research Army, you are not signing up for a study right then. You're signing up to hear about research and get emails about research. And so it's a way to also learn about what studies are going on and find something that you might be interested in as well. So we're going to close today, and I'd like to thank all of our guests and panelists one more time for joining us today. This was a very important topic, and I encourage all of us to continue this conversation with our peers, colleagues,
Right.
and families.
And I just want to say one thing, that the WISDOM study is definitely not the Tuskegee experiment. And no one will be treated like the Tuskegee Airmen or Henrietta Lacks. And the Army, the Love Army of Women, will never promote a study that isn't about inclusion for everyone. And what you want to know is that you will be treated equally to everyone in the study, and your participation will make sure that people like you will be included in all these policy recommendations about screening. And the reason you should care is because breast cancer is a serious disease, and we want to put an end to it. We want to end the death from lethal cancer. We want to end the overtreatment of indolent cancers and low-risk cancers. And the only way we can do that is if everyone steps up and participates and say, I want this to be about me, and I'm in, not just for today when I fill out my survey, but I'm going to participate and make sure my information is counted. I want to step up and be counted so I can say I participated in reducing death and morbidity from breast cancer.
Thank you, Dr. Esserman. I
Indeed.
appreciate that. Well, again, we appreciate everyone being here and hope you are all staying safe and healthy. And we look forward to future webinars and having everyone join us again. Thank you.
Thanks for having us.
Thank you all.
Thank you all.